Hello, guys, and welcome back to Counter 10. My name is Arnie, and today we have a very special guest joining me. This is the third time of him being on this pod, and I just keep roping him back in to do one more episode. You might have seen him with his practice live Viva demonstration that he did with me, or heard him on our primary exam tips pod. But today we're going to discuss a topic that sometimes gets forgotten in the curriculum, but has come up more than once as both SAQs and Vivas, and that is immunology and hypersensitivity. This is a bit of a hidden gem topic because if you know it well and get it in the exam, then you can really get some high marks out of it. So let's dive straight into it.
One, two, three, four.
Hey Justin, thanks for joining me. I guess the opening question I have for you is there something in the talk that when you've done it a couple of times now that's a hidden gem that people should be looking out for without kind of ruining your talk before we get into it?
After talking to one of the examiners at Caboolture, the only thing that they want to know is a good definition for hypersensitivity reactions and a good understanding of anaphylaxis.
We've kind of come full circle as well because I remember giving you hypersensitivity live Viva as well. And now you're doing a talk on this pod about hypersensitivity and anaphylaxis. It's funny how things kind of work out.
And I still don't know what I'm talking about, so we've come full circle indeed.
For those listening to this episode, it'll also be out on the YouTube channel with the PowerPoints, so you can watch it there. You can also see my dirty mo that I have on. We're recording this on the 29th of November, so it will be shaved off in a couple of days, as per my wife. But enough of that. Justin, are you ready?
I am also very envious of your mo, as I cannot grow one myself.
Well, let's dive straight into it.
All right. So my topic today is immunology and hypersensitivity reactions. And this is, like Arnie was saying, a very peripheral topic in which that if you know it well, you can score good marks during the exam. So moving on to this slide here. So this is what we call Bloom's taxonomy. It's a framework for categorizing educational goals and learning outcomes. And looking at the learning objectives from ANSCA, the first two basic levels here are the ones that they expect you to understand and remember for the learning objectives that they've outlined as well. So remember is just recalling basic facts and understanding, being able to explain some ideas and concepts. So this idea can be, the pathophysiology of anaphylaxis. So these are the learning objectives today. So explain how the body defends against infection, outline the effects of anesthesia and surgery on immune function, and describe the immunology and pathophysiology of hypersensitivity reactions. According to the definitions of the term, so explain is make plain or interpret and account for. Outline is give the main features, so just the main structure of the effects of anesthesia, and describe is give a detailed account. So the college expects you to know a very detailed amount of information on immunology and the pathophysiology of hypersensitive reactions, mainly anaphylaxis. So these are the previous SAQs that have been asked in the exam. And so in 2013 and A and B, this was when the new curriculum was started. There were a very broad question, write brief notes on innate and acquired immunity. Since then, this has not been asked. So that's probably a good thing for everyone, but it could be one that they could repeat again. So who knows? And in 2017, B11 described the immunology, mediators, and pathophysiology of anaphylaxis came up and do not discuss management. And so since then, we haven't had any other questions on immunology.
Interestingly enough, Justin, they've both got pretty high pass rates, which is kind of a weird thing because you think it's a peripheral topic, but they're both in the 60% pass rate.
Perhaps they didn't require much for a pass mark.
And yeah, that's true. And sometimes that happens with peripheral topics that don't need you to know a lot, just a little bit. And that's reflected in the question being write brief notes.
And looking at the examiner report as well, what they wanted was the mechanisms of the innate and acquired immunity, as well as the roles of cells, including the immunoglobulin as well. So there was quite a large breadth of knowledge they required, but hopefully they don't ask that again. And so previous Vivas as well, this has come up a few times. So one of the questions is what type of hypersensitivity reaction is anaphylaxis? The other second question was basically the same. What kind of, just in an extended stem, and what is the physiological basis of anaphylaxis? And this was asked, 5 times in the past 10 years or so. And apparently it was recently asked in the most recent sitting of the Viva as well. And so by the end of today's session, I would like listeners to just have a brief explanation of how the body defends from infection, give the main features and principle of how immune function is affected by anesthesia and surgery, have a good definition of anaphylaxis, and somehow understand the immunological basis of anaphylaxis, and relate this to treatment and pharmacology so that we can apply this to real-life application. So the first LO, how does the body defend against infection? So some of the definitions and buzzwords that we should probably know off the top of our heads are the classification of the immune system. So you're innate and adaptive. We should know what humoral means, so humoral, cellular, hypersensitivity, anaphylaxis, immunoglobulin. Arnie, do you have any ideas what the innate immune system means to you?
Well, yeah, I start off with that classification and then divide it into 3 different types. So if you have to broadly define innate, the way I would define it is the immune system that you have since birth. It has no memory. It's your first line of defense, and it gives the same response every time. And the difference between that and adaptive for me is adaptive has the function of memory. So while it also gives the same response, it has the ability to adapt and therefore prevent infections. And I think if you remember that and you start off a Viva with those opening words, as someone that gives a Viva on immunity, because it's a peripheral topic, I know that you've covered this topic well.
Yeah, 100%. And so the innate immunity is broken up down into your barriers, your chemical and humoral, and your cellular components. Your barriers are your basic things like skin, mucosa, cilia, and mucus. And your chemical humoral are your things like your stomach acid, lysozymes. Humoral components are your complement acute phase proteins like CRP. And you have your cellular components such as your phagocytes and natural killer cells. So these are the ones that go in, destroy the foreign material.
Justin, I have a question for you. Where do you put reflexes within innate immunity, or do you have that in your classification?
I do not have that in my classification, actually.
Because that's
Where
one
does
thing
it
I
come
always
from?
get confused with is like, where does the cough reflex go and other reflexes that like vomiting that is not so much of a reflex, but are innate physiological adaptations that happen that help with kind of the barrier protection. But I don't know whether it fits into barriers or another type.
Yeah, from what I've read in many textbooks, they don't include the reflexes. So that can also be one of the physiological mechanisms as well. The complement system, I'll have a discussion about next. So the complement system are essentially just proteins that destroy microbes. I know in the KICM exam or the SICM exam, they do ask about the complement system, but I do not think that ANSCO will ask this question because it's way too detailed information. Essentially, all we need to know is that what it does, it causes opsonization, which is where proteins envelop a particle, and this causes essentially the white cells to come and destroy the foreign material. And there are a common pathway, which C3 becomes C3A and C3B, which are all inflammatory cytokines as well. And then this causes the membrane attack pathway. Apologies for my spelling mistake there. But yeah, so essentially complement is a protein that destroys microbes and foreign material and is part of the innate immune system. And some of the functions of the cells, so we have phagocytes and also granulocytes as well. And so these are your neutrophils, your macrophages, dendritic cells, and natural killer cells. Neutrophils degranulate cytotoxic contents and cause damage to pathogens, whereas macrophages phagocytose and kill opsonized pathogens activated by the complement system. Dendritic cells phagocytose and present antigens to the cells of the acquired immune system. So this is how innate and acquired immune systems are related, and that's how the acquired immune system gets their response. And natural killer cells recognize abnormal cell surfaces expression and directly kill infected cells as well. Natural killer cells keep that in the forefront of your mind, as we can talk about more about that later as well. And so the immediate immune response to any foreign material entering the body is the initiation of inflammatory cascade. You get adhesion of molecules from complement, you get cell recruitment, and then you have phagocytosis and intracellular killing occur. And this happens, within minutes to hours. And so the next component of the immune system is the adaptive immune system. This is slow and highly specialized and has memory as well. And once again, this is split into humoral and cellular components. So humoral being from dictionary, from human or bodily fluids. But in this circumstance, immunoglobulin, which is a protein, and cellular, which are your lymphocytes, your T and B cells. So talking about the cellular components, we have T cells, classified further into CD4 and CD8, CD4 being T helper cells and CD8 being the cytotoxic cells, which cause destruction of the molecules. CD4 cells are T helper cells, essentially, and what they do is increase the immune response to infection. And then there's B cells as well. B cells are split into plasma cells, which secrete antibodies, B cells, which are your memory cells.
That classification of T cells is really important to know. It gets asked in sometimes MCQs as well, knowing you're differentiating between CD4s and CD8s and what T helper cells 1 do versus T helper cells 2 do as well. So it's a really important classification to remember.
So T helper cells 1, intracellular infection, T helper cell 2, extracellular worms and parasites, and T helper cell 17, adaptive response. And T regulatory limits that immune response, so you don't get an over response to the infection and you get destruction of your healthy tissue or healthy cells as well. And just briefly about immunoglobulin. So immunoglobulin is a protein complex and it comprises of 2 heavy and 2 light chains. There are 5 types essentially, and I remember the mnemonic MAGE. I'm not sure if everyone uses that same mnemonic from med school or whatever. So MADGE. Don't worry about D. D has an unknown role, but IgE is for mast cells and eosinophils and contain the FcR receptor, which is important in anaphylaxis. G is the major immunoglobulin and is important in secondary responses through interaction with foreign material and also crosses the placenta and provides that passive immunity that the fetus gets during pregnancy. M is the early release during an acquired response. So they're the ones that have increased concentration in an acute infection. And then you have IgA, which is a mucosal lymphoid tissue, and it was one of the first barriers also involved in the innate immunity as well. So this is a little diagram of immunoglobulin. And so we have the heavy chain here, and we have the light chain here as well. So the variable regions are actually in the light chain.
And if you're doing really well in the Viva, they might ask you about this.
I've seen this question in an MCQ, if I recall correctly, from years ago, but hopefully they don't ask you this question again. And so this is a nice summary from Arnie's favorite book, Power and Cam, components of the immune system. And I think as long as you can remember these broad components broken down to physical, chemical, and cells, innate immunity, acquired immunity, there's a good basis to answer any SAQ question or any Viva question, I think. And the rest you can just fill in the detail.
Yeah, certainly they're not expecting Kickham level of knowledge for this, anesthetic level knowledge in terms of broad brush strokes, and then applying that in the anesthetic setting. So understanding how is the physical barrier affected under anesthesia? How is the chemical barrier affected under anesthesia? And every one of these gets affected. And you can see how those questions can be then asked in a SAQ or a Viva format because they do relate back to giving an anesthetic. And so that's the important things you need to be able to recognize when you talk about the physical, chemical, and cellular components of both the innate and the acquired immunity.
Yeah. And then moving on to the next LO then, the effects of anesthesia on the immune system. So there is a little short summary in Power and Cam regarding effects of anesthesia on the immune system. I tried to do a lot of searching regarding this actual topic and I couldn't find much information on it. And this is all from Power and Cam. So what anesthesia does, it affects, like Arnie was saying, physiochemical barriers, the tracheal ciliary activity, depresses of phagocytosis. It also depends on the degree of surgery stress as well. Like a higher stress obviously will cause a more depressing effect on the immune system, and also causes post-operative depression of lymphocyte function, and T and NK cell are also depressed as well. There have been some studies that showed in vitro studies have showed that it depresses NK cells, is maybe associated with an increased risk of recurrence in cancer. However, this has not been proved in human studies yet. And the way I like to think about it is via A to I approach in terms of how anesthesia can affect a patient. So the airway, we bypass the nasal humidification and tracheal ciliary effect. Breathing, we reduce tracheal ciliary motion. Circulation, we can introduce infection via cannulas. Drugs, our volatile agents can potentially reduce NK cells. Corticosteroids can dampen the immune system as well. Exposure, we're making the patients cold. Hypothermia potentially can dampen the immune system. Fluids, renal, introducing IDC, introducing infection, GIT, NGT, also the same thing. Hematological stress response, dampening the immune system, infection, surgical site, or any other foreign material that we're introducing to the patient. Do you have anything else to add, Arnie?
No, that's a really good way to think about it. And I think if you were stuck, you would just go back to that approach because that's
Yeah.
very systematic. Really, all the things that you would need to get like a solid 3 out of 5 in an SAQ.
So hopefully everyone's still awake. We're moving on to the next part, the last LO. So the part we're spending more time on. So describe the immunology and pathophysiology of hypersensitive reactions. So there was the SAQ, describe the immunology mediators and pathophysiology of anaphylaxis. But we'd like to first of all define what hypersensitivity means to you. How would you describe what hypersensitivity is, Ani?
That's a hard question. I would start off by saying that it's a all or nothing response if we talk about type 1 hypersensitivity. But obviously, there's different types of hypersensitivity. So I'd be curious to see how you define it.
Okay, so I cheated and I got this definition from Power and Cam. So this is an exaggerated or inappropriate immune response that causes tissue damage. Something very simple that Power and Cam has defined it as. And I think that's a really good, simple way to just define it and get it in your head. So just an exaggerated response, immune response that causes tissue damage. Full stop. And so we'll just move on to then type 1 hypersensitivity. So what is type 1 hypersensitivity? Role reversal.
So this is classic anaphylaxis or an allergic reaction. The way you define it is that this is an all or nothing response to a foreign stimuli, and it is predominantly instigated by mast cells being degranulated, secondary to the recognition of something that is considered to be a foreign substance.
Okay, good.
Does that sound
So
like does that sound like a pass mark to you?
you're the expert. I'm not the expert. I think that's definitely a pass mark. So my understanding, so the basics, as you mentioned, is the IgE mediated response. And we know from before IgE is released by our mast cells and eosinophils. And essentially there are two phases. We have our sensitization phase, where we get first exposure to the antigen, and then second exposure, which is what we call reaction phase. And what happens is you get mass release of histamine from our mast cells, which causes increase in vascular permeability and capillary leakage, leading to distributive shock. Going through the immunological basis now. So as you can see here, we have a mast cell with histamine granules inside. And as antigen binds to this membrane-bound IgE, you get cross-linking of the IgE receptors, and then we get histamine degranulation. And this is another diagram here, which shows the full cycle where you get the first exposure. Again, IgE is made for the antigen and memory for this is held within the plasma cell. And future exposure to the antigen results in large-scale IgE production and binding to the Fc receptors of the mast cell. And then antigen binds to the IgE on mast cell, causing activation. And you get activated mast cells degranulate, releasing histamine and other vasoactive compounds. And so, do you know what these compounds are?
Oh, this is a audio only podcast, Justin. So like
Oh, okay, sorry.
no, I'm joking. I don't know what these compounds are. They look like they have multiple groups, but Justin's given me a slide with clinical relevance and he showed me multiple things with chemical structures. And so therefore I'm
Yeah.
going to take an estimated guess and say these are the most common drugs that cause anaphylaxis. So I'm going to say there's sucks here because it looks like it's a kind of mirror image of each other.
Yeah, you're right. So, all right. So the bottom one is sucks, and then the that one on the top right is Volcadine. And what they have in common is the tertiary amine group or the quaternary amine group, which is what apparently hypothetically causes the anaphylaxis and cross reaction and cross reactivity.
And that's a really important point because if you go back to your previous slide, we were talking about that reaction that causes the first exposure and second exposure. You don't necessarily need to have the first exposure to the same drug that you're going to give as the second exposure. As long as the chemical makeup of the drug is similar, the first exposure can be through a similar drug, which is what happens with rock. And then the person gets rock uranium for the first time and they get anaphylaxis. And then you think to yourself, well, they can't get anaphylaxis. That's the first time they've had rock. That should be the first exposure, not the second exposure. But because of the chemical similarities, that can occur.
And so now we'll talk about briefly about the mediators that are released now. In the cell themselves, there are some preformed mediators. These are histamine, serotonin, bradykinin, and tryptase. And then secondary, as anaphylaxis continues, there's newly formed substances or mediators such as leukotriene, slow reacting substance of anaphylaxis, prostaglandins, and platelet activating factors. So the common denominator and the common function of all these, the preformed mediators, are that it causes increase in capillary permeability and vasodilatation. Just a segue into now histamine and serotonin. What is histamine? Histamine is a histidine residue that's a neurotransmitter used in the brain as well as located in cells. And essentially, they bind to two main receptors, your H1 and H2, H1 being a GQ receptor, protein coupled receptor, and GS is for H2. And the effects on the heart are varying because they have H1 and H2 in the heart. H1, you get vasoconstriction in the heart. H2A, you get increase in inotropy. H1 in the vasculature otherwise increases nitric oxide, and that causes our vasodilatation and increasing capillary permeability. In the respiratory system, H1 causes bronchoconstriction, whereas H2 causes bronchodilation. So there's a bit of a weird contrast there as well. But in anaphylaxis, what happens is that we get bronchoconstriction. So H1 is the main receptor in this circumstance. Serotonin, 5-HT, is also another neurotransmitter. It's a G-coupled protein receptor as well, and it's got multiple subtypes. We won't go through the subtypes in this talk because it's not relevant, but all we need to know is that in the respiratory system, it causes bronchoconstriction, and in the cardiovascular system, it causes vasodilatation as well. And tryptase. Why is tryptase so important? Tryptase is what we measure in anaphylaxis. We measure that through multiple different time periods. And what is it actually? So it's just a protein. It's a serine protease, and it activates the complement cascade and also coagulation cascade. And it also causes vasodilatation and capillary leakage, and respiratory, it causes bronchoconstriction. So the theme here, as I keep saying, is the same thing. It's vasodilatation, bronchoconstriction, and the rest. So bradykinin is also a bronchoconstrictor. It's inactivated by ACE. And what happens with ACE inhibitors? ACE inhibitors increase on bradykinin for more clinical relevance. And then what that causes is a dry cough. So essentially, if we think about bradykinin as another bronchoconstrictor, it could probably help us remember what it does. And then prostaglandins and leukotrienes, these are the ones that are formed afterwards. They're formed later on in anaphylaxis. And this causes further vasodilatation as well. And steroids can help reduce the synthesis of prostaglandins and leukotrienes. All right. Now, a bit more clinical relevance now. So what is the treatment of anaphylaxis, Ani?
The treatment for anaphylaxis is adrenaline, adrenaline, adrenaline.
Great.
That's what you should say in the Viva, but really you take a doctor's ABCD approach and go through your ANSCA flashcards.
Good. And so how does adrenaline work then in anaphylaxis?
The key thing with adrenaline is it's two things. One is the stabilization and the prevention of degranulation of mast cells. And then the second thing is the cardiovascular beneficial effects that are secondary that come with adrenaline. But it's mainly the effect on the mast cells, which is important to stop those substances that you just talked about being degranulated further. Because once you stop those vasodilatory substances, you can then achieve some kind of stabilization and stop that cascade from being ongoing.
Yeah. And so, how much to give, where to give it, and what is the mechanism of action? You mentioned that mechanism of action. How much do we give? So, it depends, is the answer. Depends on the grade of anaphylaxis. Where to give it, we can give it IM or IV if we have access. And so, this is the latest anaphylaxis cards as you were talking about. And it just depends on the severity of anaphylaxis. So, 10 to 20 micrograms for moderate IV, or life-threatening, give 50 to 100. And after 3 boluses, we have to start an infusion. And if we do not have IV access, we can give 500 mics IM every 5 minutes on the lateral thigh.
On a side note, this flowchart is very important when you get to your part two exam as well, because MCQs get taken directly from this and the additional flowchart, which talks about the refractory anaphylaxis. And you have to know both the treatment for anaphylaxis in adults as well as anaphylaxis in kids. So it's a good one to know now when you're studying for the primary, because then it just makes it that much more easier when you're doing it for the part two, because you're just consolidating knowledge.
Yeah, and if you do get anaphylaxis in real life, you know what to do. So
Yeah,
just bring out those cards.
that's definitely more clinically important.
Then, so in terms of mechanism, then we all know this that the three main receptors, your alpha 1 receptors, beta 1 receptors, and beta 2 receptors that adrenaline binds to. I won't go through the detail, but essentially what it does is alpha 1, you get vasoconstriction, you're reducing the amount of vasodilatation and reducing the capillary permeability and the fluid shift. Beta 1, you're increasing your heart rate and contractility, increasing cardiac output in this state where the patient is potentially going to be shocked. And beta 2 receptors, we're stabilizing the mast cell mediated release, and we're also doing bronchodilation as well, improving the respiratory function of the patient. And just a bit more clinical stuff now. So this is the flow chart for refractory anaphylaxis. Everything on here to me makes sense. So noradrenaline causes vasoconstriction, vasopressin causes vasoconstriction, but glucagon, why do we give glucagon for refractory anaphylaxis? Do you know, Ani?
I wonder if it's because of glucagon's additional effects of working not through the beta receptors, activating your G protein coupled receptors. Because obviously, for patients that get beta blocker overdose, we give glucagon because it works through a different pathway. And so, my impression would be because of that.
Yeah, so you're pretty spot on. So it's an agonist at a glucagon-specific GS protein coupled receptor, which results in an increase in cyclic AMP, which bypasses the adrenal receptor. You're 100% right. So it's just another way of targeting the vasoconstrictor effect as well, the positive inotropy and chronotropy as well, bypassing the adrenal receptor. So just to recap now that we've learned some stuff. So what is anaphylaxis? Anaphylaxis is a type 1 hypersensitivity reaction mediated by mast cells. What type of hypersensitivity reaction is anaphylaxis? I already mentioned that. And what is the physiological basis of anaphylaxis? We've already mentioned some of that with the sensitization and then the second exposure causing a reaction in the anaphylaxis. This next slide's more for the part 2 exam, but I just thought I'll put it in just because we probably need to know something about the NAP6, which is the National Audit 6, which looked at essentially anaphylaxis. Just briefly, just 1 in 10,000 anesthetics had an incidence of perioperative anaphylaxis. And the most common triggers were antibiotics, muscle relaxants, and chlorhexidine. 96% of patients survived. And the most common presenting feature was actually low blood pressure. Would you like to say anything else about this slide, Arnie?
Yeah, I think the interesting thing with European and especially UK practice is that the antibiotic choice is also different. So they use a lot more tycoplanin compared to us because I think Vanc just takes too long. I think Tyco had really high rates of anaphylaxis, but they just don't give it in large number of patients. So therefore, the number in terms of overall quantity of what people were getting as prophylaxis was still penicillin based. The interesting thing about the low blood pressure is that we commonly think that tachycardia is going to be the first thing we see. So when you get the patient that you've just induced and you get the blood pressure cycling repetitively and not giving you a number, but the heart rate seems to be, high, but not too high, maybe around about 90 to 100, just have that in the back of your mind. Because I think our gut instinct is just to give the patient a metaraminal bolus. I think certainly that's what I would do. But if you get into 2, 3 metaraminal boluses, you need to be thinking about anaphylaxis in the back of your head because it can happen anytime.
And so to finish off now, to complete the hypersensitive reactions, I'd just like to briefly talk about the rest of them because there are obviously 4 types, and we've only talked about one in much detail. And so the other 3 types, so type 2 is your cytotoxic hypersensitive reactions, type 3, immune complex, and type 4 is your delayed cell-mediated hypersensitivity reaction. And once again, Pow and Cam come to save the day has a really good summary, a table of the hypersensitive reactions. So we have type 2 cytotoxic reactions here. And so type 2 is mediated by IgG, IgM, and complement. And essentially, it's just antibody-mediated damage to target cells. So these are things like transfusion reactions, as well as autoimmune hemolysis. The way we diagnose these things are via the Coombs test, as well as antibody immunofluorescence as well. But I don't think we need to know that level of detail for the primary exam. Type 3 is immune complex. And so this is like our autoimmune type diseases like rheumatoid arthritis and lupus. And also our IgA-mediated nephropathy as well, where these immune complexes get stuck in the kidneys, causing renal failure. And the last one is our type 4, which is our delayed reaction. And this is mediated by cytotoxic T cells, macrophages, and take a bit of time to work. So the way I think about it is like when you place like a tegaderm on your skin and you take it off, and at the time there's no reaction, but when you take it off, you get a bit of a reaction there. And that's a mild version of the delayed reaction. The way we can test for this is erythema skin test induration. And that's the extent of my knowledge of the hypersensitive reactions.
That was really good. Thanks, Justin. That was a very good summary of anaphylaxis, hypersensitivity, and immune system. I appreciate you going through that. I'll also appreciate you using Power and Cam. As you know, it's one of my favorites. Got me through the primary exam. It felt really weird being on the other end, getting asked questions. Generally, I'm just talking by myself and I don't have to ask any questions or giving practice vivas. So it just reminded me that it is very hard when you're on the other end to answer questions. And the level of knowledge that you need to get through this exam is pretty crazy. Thank you, Justin, again for going through this and taking time to come and be the first special guest. I really appreciate it. I hope the listeners got something out of it. Like I said, the slides and the full talk will be up on the YouTube page and you can check it out there. We've got another special guest coming on in a couple of weeks. I hope you guys have taken away something from this talk and I'll catch you next time on Count to 10.